Symptoms of transfusion reactions are consistent with what you'd expect to occur with like an immune response, right? So you're going to see fever, chills, low blood pressure, which would also be consistent with what you'd expect to see like if you have bacteria in your blood. But this isn't bacteria here, it's just that your immune system is responding to foreign blood cells. They're not cells that can divide and cause infection, but your immune system treats it like that way. So you still get the fever and the chills, which are caused by inflammatory molecules released by immune cells. You still get the low blood pressure because part of the inflammatory immune response is that blood vessels will vasodilate. When they vasodilate, your blood pressure lowers. You also see tachycardia or rapid heartbeat, which is also consistent with infection. Again, this is not infection, but your body treats it like that, as well as nausea and vomiting. In terms of treatment of this, you guys, it's aimed at really preventing any kidney damage. I mean, once the blood cells are in there, you can't remove those foreign cells, not very effectively. Like there is plasmapheresis, but the major treatment of a mismatch, transfusion reaction, would be aimed at just protecting the kidneys, preventing that hemoglobin in the bloodstream from clogging the kidneys and leading to renal failure. So there's another interesting disease here, you guys, and we'll talk a bit about this again back in pathophysiology. But this one's is called erythroblastosis fetalis. So erythroblastosis fetalis is a situation where a mother is Rh negative, but carries a fetus that's Rh positive. Now, what's interesting here is that the placenta isn't a very precise barrier. Like you can have some blood cells cross the placenta. So in a pregnant mother, you can find fetal blood cells in the pregnant mother's bloodstream or mother cells in the fetus. So they can go vice versa. Now this is important because what this means then is that if you have an Rh negative mother and an Rh who has an Rh positive fetus, then some of those fetal cells are now ending up in the mother's bloodstream. Then the mother is now sort of recognizing the Rh factors foreign, and she can start to mount an immune response against those foreign blood cells, right? And so this is a condition where essentially the immune system starts to attack the fetus. But what we know about someone who's Rh negative is that they don't already make anti-Rh antibodies until they're exposed. So one thing that's important to note about erythroblastosis fetalis is that you typically don't see signs and symptoms of this with the first pregnancy. But upon subsequent pregnancies where you may have Rh positive fetus, again, because the mother already makes anti-Rh antibodies and has started to mount an immune response, the subsequent pregnancies that may be Rh positive could lead to stronger and stronger immune responses that could potentially put the fetuses and the mother's lives in danger. So Rogam, it's a drug. I'm not sure it's up here, but so this is important to note. Talk about the mother's Rh antibodies crossing the placenta and destroying the red blood cells of the baby or fetus. You might wonder, how is this possible? Like, how do you have a mother that's Rh negative and a fetus that's Rh positive? Well, blood type's based on genetics, right? So let's say if the fetus is Rh positive because it inherited rhesus factor from the father's genes. That's how one way you can have Rh factor in the fetus and have a mother that doesn't normally express Rh factor, if that makes sense. Yes?
Wouldn't it just be simpler, rather than to risk erythroblastosis fetalis, just to give all mothers Rogam? If they're Rh negative?
You mean like what?
I just mean in general.
The thing about Rogam is that Rogam are antibodies against Rh factor. And the thing about that antibody against Rh factor is that would be a foreign antibody, a foreign protein, which means that if you did give pregnant mothers Rogam, they can start to make antibodies against the drug, the Rogam drug, which means that they could become immune to that drug. And if that happens, then there's nothing you can do. So you only want to give it if it's necessary, and also not in too high concentration because over time that can lead to tolerance by the mother. That's a great question. So what we're going to do next, you guys, is move on to talk about some of the major leukocytes or white blood cells in the body. And unlike the erythrocytes, these are actually our true cells. They're far less abundant than the red blood cells, but they are involved with the immune response, and so they can help defend your body against invading pathogens. These happen to be about 1.5 to 3 times larger than erythrocyte because of their nucleus and organelles, and they're capable of what we call diapedesis. Diapedesis is a process where leukocytes can leave the bloodstream and enter an infected tissue. And they do this through a process known as chemotaxis as well. Chemotaxis means chemical movement, and cells can be attracted towards certain chemicals. So let's say if you get like an infection in your skin and you want leukocytes to leave your bloodstream and enter that infected tissue, what happens is that there are some inflammatory molecules released by the cells in that infected tissue. And what those inflammatory molecules do is they attract leukocytes from blood into the tissue. That's chemotaxis. And the way that those white blood cells leave is they leave through diapedesis, where they physically squeeze between the cells that make up your blood vessel wall. They leave the bloodstream and enter that infected tissue. It's actually a really cool process. Now, there's two main types of leukocytes. We got the granulocytes and agranulocytes. The granulocytes are the neutrophils, eosinophils, and basophils. The agranulocytes are lymphocytes and monocytes. And you might wonder, what's the difference between these two? Well, these granules that you find in the granulocytes are basically little vesicles that are full of histamine or lysosomes. Okay, so it turns out here, you guys, that these can be associated with histamine release, and the agranulocytes lack those granules. You don't find the histamine granules in lymphocytes and monocytes, so they can't release that type of molecule. Now, what this slide shows then are the major types of leukocytes that you find in the bloodstream. So here's a lymphocyte, and this is really characteristic because while the cell is inactive and floating around the bloodstream, it turns out that the nucleus takes up the majority of that cell, and there's not a whole lot of cytoplasm left behind. So most of the cell is just one big old nucleus. But once this activates, it'll turn into a different cell type, like a B cell or T cell, that kind of stuff. Now, neutrophils are characteristic because they are the granulocyte variety, and they have this bilobed nucleus, and you can see the granules here. Now, neutrophils are also a form of phagocyte, and they phagocytose bacteria. We call neutrophils part of your first line of defense. Like if you have a bacterial infection, it's the neutrophils that arrive first, and they're the ones that are going to really help engulf and remove any foreign bacteria. And the way they do this, you guys, is that neutrophils are part of your innate or non-specific immune system. You don't have to train neutrophils how to fight infection. They just already know how to respond to many different foreign antigens, not just one foreign antigen. So if it's just foreign antigen in general, the neutrophil will target that and try to remove it. That differs from the lymphocytes because lymphocytes only respond to one type of foreign antigen. And we'll come back to this when we talk about the lymphatic system, and we get to some more detail on the immune system and lymphocytes in particular, and how this is part of your adaptive or learned immune response because these cells can specifically target one type of foreign antigen. Now the eosinophils here, you guys, are also in the granulocyte variety. These are also phagocytes, and they're also involved with the allergic response and parasitic infection. So what's really interesting here, you guys, is that allergies and parasitic infections seem to be controlled or mediated by the same cell type. And there's an interesting phenomenon where if someone is more chronically infected with a parasite, they're less likely to have allergies. And if you're more likely to have allergies if you're less infected with parasites. So where do you find allergies? Well, in places of the world where people don't really encounter a lot of parasites, like the United States. We don't have a lot of parasites that infect humans here. You know, if you travel to the tropics, there's a lot of mosquito and vector-borne parasites that can infect humans, and so you find less autoimmune disease and less allergies in those parts of the world. You might wonder, well, what mediates this? Well, it's almost, think of these eosinophils as like getting bored, right? If they're normally involved with fighting off parasitic infections, but if you're not infected with a parasite, what are they going to do? Well, they could just be hypersensitive to some sort of allergen, and that's how you get allergies in that regard. So what's weird is that there's actually a therapy where you can diminish someone's allergies and autoimmune disease by giving them a parasite. There's one called helminthic therapy. They do this in Brazil. Like if you have an autoimmune disease that's severely debilitating, you could take like a pig tapeworm, roundworm, intentionally infect yourself with this tapeworm, and it actually diminishes the symptoms of your autoimmune disease. Now, we don't do this here because the FDA would never approve of that, right? But what they are trying to do, though, is actually specifically find the antigens of parasites that your immune system responds to. If you can identify those, then you can just deliver those antigens to someone's body without having to give them the actual parasite. That way you can get a similar immune response without the infection. So it's interesting. And we'll come back to that later. Now, basophils, you guys, these are part of the allergic response as well. But these are found abundantly in most tissues of your body, and they release a molecule called histamine. Think of these as like the little sentinels, like monitors of infection. When they sense infection or damage, they release a type of molecule called histamine. And what histamine does, it's an inflammatory molecule that causes things like vasodilation, so you get an increase in blood flow, and it also attracts other immune cells to the site of infection. Okay, it's involved with allergies as well. You know, this is why people take antihistamines to diminish the effects of these cells to make their allergies less pronounced. But these are pretty interesting too. And then we have the monocytes. And these monocytes are, think of these as like an inactive macrophage. These are not in the granulocyte variety, but basically the monocyte, you guys, once it's activated into a macrophage, it can engulf and remove foreign debris and pathogens. Now, it does this through phagocytosis, where once it encounters a foreign pathogen, the monocyte macrophage will engulf that thing, take it into the cell, and then break it down with lysosomes. Okay? Now, the monocytes are also what we call antigen-presenting cells, because once they break down that thing that they engulfed and ate, they actually take those proteins of the thing they ate, they put those antigens on the cell surface of the cell, and then the monocytes travel on over to a lymph node, and then basically show those antigens to other immune cells in a lymph node to say, like, hey, look what I caught. Look out for the antigen, because it seems to be in his body, right? They're kind of show-offs, yeah, exactly. And we'll talk about this when we get to the immune system after the midterm in several weeks, but they're actually really interesting cell types. You had a question, right?
Can you remind me of the mnemonic of this really fast?
Oh, yeah. So there's the relative abundance of these immune cells, and it goes from neutrophils to lymphocytes to monocytes to eosinophils to basophils. And the mnemonic is never let monkeys eat bananas, where the neutrophils are the most abundant and the basophils are the least abundant. And so it's important to talk about how abundant these cells are in a normal body, because what if someone has a cancer of the immune system, and you find that the basophils are now like the second most abundant rather than the least abundant? Well, that can indicate maybe a cancer of that cell line, which we need to be treated. Now, platelets were another formed element that we found in the buffy coat of blood. And these are basically small, irregular, membrane-enclosed fragments that actually come from another cell type called the megakaryocyte. This megakaryocyte is a huge cell you find inside of red bone marrow, and it has these extensions that stick out. And what happens is little pieces of those cell extensions get cut off. Those little pieces of the cell become platelets. So blood platelets are the pieces of the megakaryocytes. And so platelets are actually full of clotting factors. So we talk about platelets as being not only involved in blood clotting, but it's because they are full of factors that aid in the process of blood clotting. So they're full of things like serotonin, calcium, ADP, platelet-derived growth factor, and other enzymes that help aid in the clotting process. Okay? So things like ADP, platelet-derived growth factor, and calcium can attract other platelets to the site of injury. So once you get activated platelets, they can release these clotting factors that not only attract other platelets, but also activate the clotting cascade. Calcium is a very important atom here in the clotting cascade, and without a sufficient amount of calcium, then you won't get a blood clot. If that makes sense. Now, the normal concentrations of platelets in your blood per milliliter, so a milliliter is a cubic centimeter, and you should find 150,000 to 400,000 platelets per mil. And 1 mil, you guys, is 1 drop. Like, think about 1 little drop. You can find up to 400,000 platelets in 1 little drop of blood, which is pretty phenomenal. I don't even mean like concentrated blood. Like, I'm not talking about if you spun down blood and then looked in the buffy coat. I'm talking about if you just take whole blood, where everything's all dissolved and mixed around. In that whole blood, you can find up to 400,000 platelets per mil. So there's a tremendous amount of these dissolved inside of your bloodstream. Now, these platelets are formed by the megakaryocytes. So you find these in the red bone marrow. And this is showing what a megakaryocyte looks like. It basically has these long extensions that project into your bloodstream. And these extensions basically form little blebs, or kind of pinches off into these platelets. So the platelets are basically just little blebs or pinched off pieces of the cell that are the thing, this platelet. Now, you also find that platelets are called thrombocytes. So when we talk about diseases of platelets, we'll say things like thrombocytosis or thrombocytopenia. these are not true cells, but when they were first being looked at under the microscope, they were suspected to be cells, bless you. And so we call them thrombocytes, although they're not a true cell. They're mostly just a little fragment of a cell, and they're made by red bone marrow. Now, we're going to move on to talk about hemostasis next. And hemostasis is a fast series of reactions that aid in the stoppage of bleeding. And this requires a variety of things like clotting factors, platelets, as well as injured tissue to stimulate the process. Now, hemostasis occurs in 3 main steps. Vascular spasm occurs first, platelet plug formation occurs second, followed by coagulation or blood clotting. So with the vascular spasm, what happens is that once that blood vessel is damaged and ruptured, and there's the potential for blood to leave the bloodstream and enter the tissue, the first step here is that the blood vessel will actually spasm really quickly, right? So it starts spasming. So you get vasoconstriction, dilation, really fast. You might wonder, what's the point of that? Why would you want a blood vessel to spasm? Well, the way it's moving is by smooth muscle contractions, and the spasm, like the blood vessel spasming, makes blood more turbulent, okay? And so by having blood more turbulent, it's more likely to clot. That's one of Virchow's triads in blood clotting, is that turbulent blood is more prone to blood clots. So these vascular spasms, the first step, make blood more turbulent and therefore stimulate clot to form in that regard. The second step, you guys, is that these platelets can respond to exposed tissue. So when the blood vessel gets ruptured, you'd expect there then to be tissue that's deeper that's now exposed to your bloodstream, which should not be normal. Normally your bloodstream should be separate from the tissue because there's a vessel wall. But if you have exposed collagen, these platelets can actually sense that exposed collagen, not consciously, but they respond in a biochemical mechanism. These platelets can actually respond to exposed collagen, like deep in the tissue. That activates the platelets, causes those platelets to release clotting factors, and then it attracts more platelets to the site of injury. What that does then is it causes a platelet plug to form. And this platelet plug is, like it sounds, a plug of platelets in the ruptured vessel. Okay? Third step, these platelets release clotting factors that help initiate the clotting cascade. Okay? Now that has to come in conjunction with the exposed tissue. So once you have exposed tissue, there's other clotting factors that are released. The platelets release clotting factors and initiates a clotting cascade through 2 main pathways. We got an extrinsic and an intrinsic pathway that all lead to the formation of a fibrin mesh. Because what happens is that inside the bloodstream we have fibrinogen, the inactive precursor to fibrin, and that fibrinogen gets converted to fibrin once those clotting factors are released. And it causes a cascade that leads to coagulation or blood clotting. So what this slide is showing you guys are those 3 steps again. We got vascular spasm, platelet plug formation, and coagulation. What was the purpose of the vascular spasm? Makes the blood more turbulent and therefore makes it more prone to clot. Exactly. But what about if you had turbulent blood in a place that you didn't want it to be turbulent? Like let's say if you had like a blockage in an artery due to like plaques, and that caused the blood to be more turbulent in that little area, you could still get a blood clot that forms even though you don't want a blood clot there. And so what's important to note, you guys, is that blood normally flows in a laminar fashion. Laminar flow is just where it all kind of flows in the same direction without a lot of turbulence. You've all seen laminar flow before. It's those creeks that are like so clear you can see right through them, and there's no white water, and they just kind of move like slowly and together, and there's not a lot of turbulence, right? And they're so clear you can see right through them. It's the kind of creeks that like it almost looks like the water's not moving because it's so still. I mean, not still, like it's not turbulent, and so it doesn't like change the way the light looks through the water. So it looks like it's still, but it's actually flowing. That's laminar flow. Human blood flows like that. Blood should normally flow in a laminar fashion, but the vasospasms here, the vascular spasm, causes the blood to become more turbulent, more like white water, and that can stimulate clots to form. Okay. Now, what happens next is the platelet plug forms. So what actually initiates this platelet plug? Yes, exposed tissue. So if you look at this vessel here, it's ruptured, torn. There's underlying collagen that's deeper now. Now it's exposed to the bloodstream. That's not normal. You shouldn't have collagen just exposed to blood. Platelets have receptors for exposed collagen, and when the platelets encounter this exposed collagen, they can release factors that attract more platelets and they become more sticky. And that forms the platelet plug, right? Now, the last step you guys hear is coagulation. And this is where the platelets in the injured tissue release clotting factors that convert a plasma protein. So what's the plasma protein that's the precursor to the clot? Fibrinogen. Good. So there's clotting factors that convert fibrinogen into fibrin, and fibrin forms a really big mesh, like fibers, hence the name fibrin. In fact, the way this is converted, you guys, is that there's different pathways that get activated. And we'll talk about this here in a minute. But we have this prothrombin activator that activates prothrombin into thrombin. Thrombin is an enzyme that cuts fibrinogen into fibrin. Okay, so you guys ever heard of prothrombin time, which is a measure of your blood's ability to clot? They can basically measure how fast your prothrombin can be converted to thrombin, which also tells you how fast the blood could potentially clot. Okay, but thrombin is an enzyme that converts fibrinogen into fibrin. And why have multiple steps? Why even have like a prothrombin activator and have all these steps that lead to the formation of fibrin? You got it. By having all these steps, you guys, every step is a checkpoint, right? And by having lots of steps, it ensures that you're not just getting random blood clots, and that you need to have lots of things that occur in sequential order under the right conditions for blood to coagulate. Because you wouldn't want your blood to just all of a sudden go from a liquid to a solid, and that wouldn't make sense. It could lead to death, right? So it wouldn't make sense. So what this slide is shown here are the extrinsic and intrinsic pathways. So the extrinsic pathway here, you guys, comes from the tissue damage itself. And so the damaged tissue causes the release of tissue factors that activate a clotting pathway that leads to the activation of what we call factor 10. Factor 10 is called Hageman factor, and it's one of the common factors in both the extrinsic and intrinsic pathway. The intrinsic pathway comes from the clotting factors from platelets, and these can actually also lead to the production of Hageman factor, factor 10. Once you've activated Hageman factor activates prothrombinase. Prothrombinase is an enzyme that converts prothrombin into thrombin, and then thrombin is an enzyme that converts fibrinogen into fibrin until you get the fibrin mesh here. So what does this look like then? Well, here it is. Here's a blood clot underneath an electron microscope. These are the red blood cells, you guys. And then there would be some platelets. Yeah, here we go. Here's some platelets here. And then all of this stuff that looks like spaghetti, or I don't even know, silly putty, or what was that? Silly string. Remember that stuff? Yeah, it looks like silly string to me. That's fibrin. It's activated fibrin, but fibrin came from fibrinogen. And what's the enzyme that converts fibrinogen into fibrin? Thrombin. And then where does thrombin come from? Prothrombin, right? And then how does prothrombin get from factor X? Nice. So prothrombin is converted to thrombin by prothrombinase, which is also activated by Hageman factor, or factor 10. Factor 10. Very good. So this is what a blood clot would look like under 5,000x. So using a scanning electron microscope. It's actually pretty cool. Now, what happens next, you guys, is after you've made the clot, the next step here is clot retraction, because platelets are full of actin, and that actin will actually start to pull on each other, and it causes all the platelets within that fibrin mesh to start to contract. But because the platelets are stuck within the fibrin mesh, it also pulls on the mesh, which pulls the edges of the tissue together. And so think of clot retraction, you guys, as like a natural suture. The platelets within this clot are starting to contract. And by contracting, they're pulling the edges of the damaged tissue closer together, which improves healing time. Because if the edges of the tissue closer together, you have to fill in less tissue. Now, this does not only does it improve healing time, but it also helps squeeze out any of the other clotting factors. So it limits the size of the clot. So by contracting the clot, clotting factors are squeezed out, they're pushed out, and so it prevents further clot to form, if that makes sense. And it's a really, really neat process that this was only discovered about 30 years ago. So when my father was a student in the 80s in college, his professor was the guy who discovered this process, the clot retraction process. So it hasn't been known very long, but it's a really interesting process. Now, vessel repair would come next, right? We understand that once the vessel is damaged, that you need to repair that damaged vessel. And so healing occurs after the clot retraction phase. And it's mediated by a variety of factors. Like for one, we have platelet-derived growth factor, PDGF. This is actually released by those platelets themselves, and it stimulates the division of things like smooth muscle cells, fibroblasts, and what these do is help repair the damaged vessel wall, okay? Because we know that blood vessel walls have several layers. There's an inner layer of endothelium. It's kind of like a simple squamous epithelium. We have a middle layer of smooth muscle, and then an outer layer of like fibrous tissue, okay? Fibroblasts are the cells that make connective tissue proper. So these fibroblasts are stimulated by PDGF, or platelet-derived growth factor, and once you activate these cells, they start to repair that damaged tissue. If you guys remember going back to skin, we talked about a very, very similar process. We talked about wound repair in skin, how you had the clot that formed, then the macrophages came in, they started to break down that clot, then the fibroblasts came in, they started to lay down new connective tissue proper in the dermis. Well, the same process occurs, but in a blood vessel wall, and that process is stimulated by this growth factor, PDGF. That's one of them, okay? But what if the tissue is so injured that you actually wiped out large sections of blood vessels? Like, as the tissue repairs, there's no new blood vessels in that tissue. So what you would need to do then is attract new blood vessels to grow into the damaged tissue. That's being mediated by a type of hormone called VEGF, or vascular endothelial growth factor. VEGF is released by hypoxic cells. So cells that aren't getting enough oxygen release this hormone, VEGF. What VEGF does is it stimulates blood vessels to grow to the site of hypoxia, or to the area where there's low oxygen levels. So VEGF helps improve blood vessel growth in the damaged tissue, right, as it's repairing. That makes sense. Now, some years back, you guys, VEGF was a big potential target for cancer because some of your more vigorous cancers attract their own blood vessels into the cancer, and that way they can actually get more nutrients to grow more quickly, right? So it was believed that VEGF could be like the cure for cancer, right? Like if you can block this pathway, you can prevent cancer cells from attracting their own blood vessels. The cells would divide and basically starve themselves to death, right? But it turned out that this pathway is way too complex to have one thing to target its pathway. So there was a big hope that it was going to work maybe about 15 years ago. It's still not off the table, but it seems to be much more complex than we thought. Yeah.
Would you use it for patients that have had heart attacks where parts of their vessels surrounding the heart have been completely severed?
You could.
Regrow that tract?
Yeah, you could. You can grow new blood vessels into some damaged tissue. And you wouldn't actually even need to deliver this, pharmacologically, because the tissue releases itself. Like the damaged tissue, when it's hypoxic, it releases its own hormone that also stimulates blood vessels to grow in. So this is a normal part of the healing process. Could you speed it up if you added it like exogenously? Probably.
Heart transplant because they've got like a vascular insufficiency.
Oh, good point. Yeah, like if you have a heart transplant and you're reconnecting vessels together, maybe you want those vessels to heal together more quickly. Yeah, I suppose you could administer different growth factors like VEGF. Yeah. So what about fibrinolysis, you guys? The breakdown of that clot. We understand that when the clot forms, that there's different phases there. But how does this clot get removed? Because the clot has to be removed from the damaged tissue in order for new tissue to grow in. Well, it involves this process called fibrinolysis. So it removes unneeded clots after healing. And it begins as soon as within 2 days and continues for several days later. Now what happens, you guys, is that there's an enzyme called plasminogen. And plasminogen is converted to an enzyme called plasmin by factor 7 as well as thrombin. Now, what was thrombin again? Actually, I'm sorry, we haven't talked about that yet, right? Yeah. Good, exactly. Thrombin was the enzyme that converted fibrinogen to fibrin, right? Well, check this out, you guys. The same enzyme that converts fibrinogen to fibrin also helps activate the pathway that digests the blood clots. So you need thrombin as well as another factor, factor 7, to activate this thing called plasminogen activator, which activates plasmin. Plasmin is a fibrin digesting enzyme. So here's the weird thing, is the thing that stimulates the formation of the clot also stimulates the same pathway that breaks down that clot. So it's self-limiting. What type of feedback would that be? It's self-limiting. Negative feedback. You got it. So this type of biochemical mechanism is a negative feedback process which limits the size of that change. And the change here is the formation of a blood clot. Yes?
What does factor 5
there's like 12 different clotting factors that are part of the pathway here, and each one is a segment in this biochemical cascade. So if we go back to this slide here, you'll notice that we have these big old arrows, like one big arrow is going this way, the arrow is going this way, and we say that we have tissue factors here and some other clotting factors. This slide's not showing all of the detail. Like there are other clotting factors in this cascade, and it's a more complex biochemical cascade that has like up to 12 steps. And factor 5 would be part of that process. It'd be part of this sort of clotting cascade, if it makes sense.
Really common missing factor.
Yeah. Yeah, factor 5 deficiency would be one of the varieties of hemophilia. Hemophiliacs have difficulty forming blood clots, and it's a congenital disease. They're born with it, and it could be due to mutation. So it's kind of interesting. So there are different factors that limit the size of that clot, you guys. So for one, swift removal of clotting factors prevents the clot from getting too big, as well as inhibition of other activated clotting factors, and how thrombin will bind to fibrin threads, and it prevents additional fibrin from sticking on. So the existence of thrombin, although it converts prothrombin to thrombin, it also prevents additional thrombin from sticking. So that actually prevents the clot from getting too big. We have this other thing here called antithrombin 3, which inactivates unbound thrombin, and heparin is released by basophils, which also inhibit antithrombin 3, so they actually prevent the blood clot from forming. Now, platelet adhesion is prevented by things like smooth endothelium in blood vessels, antithrombic substances like nitric oxide, and vitamin E is a potent anticoagulant. You can overdose on vitamin E. Vitamin E is one of those fat-soluble vitamins, so your body can store it for later use. There are non-fat-soluble vitamins that you can just urinate out because they're not stored by your body. But vitamin E, the fat-soluble vitamin here, if you overdose on it, then it's an anticoagulant, so you can have difficulty forming blood clots if you overdose on vitamin E, which is interesting. Now, vitamin K on the other side, vitamin K is part of the clotting process. So if you overdose on vitamin K, that can stimulate blood clots to grow, or like to form, if that makes sense. And you find vitamin K in certain organ meat because organs store it. For instance, polar bear liver is toxic because there's so many fat-soluble vitamins in polar bear liver. Like if you ate polar bear liver, it would be enough vitamin dosage to kill you. You can't eat polar bear liver. I know. Otherwise, like leafy greens are really high in vitamin K too. So if people go like on green smoothie diets and they're like eating like kale and spinach as their main staple, you could overdose on vitamin K. So these things to be careful of.
So that's why it interacts with like primitive.
Yeah, exactly.